Good morning, everyone. I welcome you all to the slide seminar session 2. At the outset, I would like to thank our chief patrons, Dr. Shri Shamnur Shivshankrapaji and Shri S.S. Mallikarjun sir, for their constant support. I also thank our principal, Dr. B.S. Prasad sir, and medical director, Dr. Arun Kumar sir, for always encouraging us to conduct these academic events. I welcome all the HODs, Dr. Shashikala ma'am, Dr. Narayan Murthy sir, and Dr. Vardendra sir, all the staff and postgraduates from JJMMC, Basveshwara Medical College, and SSIMS for today's seminar session.
And all the delegates who joined.
And all the delegates who have joined the session. Most importantly, I welcome our guest speaker, Dr. Veena ma'am, Associate Professor, SHIMOGA Institute of Medical Sciences. She has done MBBS from Siddhartha Medical College, MD from JJMMC with second rank in the university. She has won best paper in KCIFM conference held at Hubli and has many publications to her credit. I welcome you, ma'am. Now I request our beloved HOD ma'am, who is the architect of this event, to speak a few words.
Good morning to all of you, and welcome all the delegates who are with us to make this academic feast a grand success. So very happy to have you here, Dr. Veena.
Thank you, ma'am.
You know what Veena is. So I kept on telling this academic feast is like homemade, food we always enjoy. And Dr. Disha, ma'am, she's honored to introduce you. She was your student.
Yes, ma'am.
So happily, she volunteered, to welcome you and introduce you to everybody. So this academic, we say, the slide seminar is a feast for us now. It's food for the brain. So festus is joyful, I believe. So the word festus means joyful. So we always kept in medical education, we always kept telling that learning must be enjoyable. So this is one way where we are meeting our own, people. So Dr. Veena, as all of you know, is one of the alumni of JJMMC. So happy to see her. I've seen her as a postgraduate student, and so happy to see her progress and be successful in her career. And she is the guest speaker for today. On behalf of everyone, I welcome you, Veena. We are waiting.
Thank you, ma'am. Thank you.
Waiting to learn from you. Let us start.
Good morning. First of all, I would like to thank Dr. Shashikala ma'am for giving me this opportunity. Thank you, ma'am. Thank you so much. So as ma'am said, to include the routine and simple cases, I've kept it very simple. I hope this will help you all. Shall we begin?
Yes.
So case 1.
Morning everyone, I am Dr. Deepthi Anu from JJ Medical College and I have been allotted case number 1. All images provided shows tumor cells are arranged in lobules with mixed white collagenous background and composed of uni and multivacculated lipoblasts along with mild to moderate atypical spindle cells. There are also seen cells with moderate to severe pleomorphism which has bizarre and hyperchromatic nucleus and a scant amount of cytoplasm. Considering all these above features, my first differential is atypical spindle cells bar pleomorphic lipomatous tumors, and other differential I like to give diffuse neurofibromas as few areas look like pseudomesonous structures. Thank you.
So this was a case 1. It was a 12-year-old child presented with the thigh swelling, and the clinical diagnosis which was provided to us was just an intramuscular tumor, and the excision was done. So this was a specimen which we received. It was with 12-year-old child with the thigh swelling, and this was a specimen we received. The consistency was a bit soft in consistency, and the cut section, some glistening areas we could make out. So these are the picture slides. You can see the nodularity here. So nodularity with loosely cellular areas. So these nodular areas are surrounded by a thin rim of perineurium here. This is the area of hypercellularity which we can see, and the mixoid change. So these loosely cellular areas with the thin walled blood vessels and some comma-shaped nucleus here and there. So myxoid change we can make out clearly. And in this slide, we can clearly see that these are the elongated cells with a wavy nucleus or a buckling of the nucleus, we can say, and interspersed with the collagen fibrils and some here and there comma-shaped nucleus. So Schwann cells with the collagenous background with a wire-like collagen. This is giving a shredded carrot-like appearance. So this is the area of cellularity, increased cellularity with some nuclear atypia here and there. So nuclear atypia is much more clear in this slide. You can see the 8 bizarre cells and some nuclear atypia, some of them showing nucleoli also, the same thing. So here the tumor part is abutting or slightly infiltrating into the adipose tissue and the skeletal muscle. So these are the vague, distorted, organoid structures which are resembling a Wagner-Meissner corpuscles or Pacinian corpuscles, the same thing in another field. So there were increased number of mast cells in this case, which was highlighted by solid in blue staining as shown here. So what all we saw, loosely cellular areas, nodularity surrounded by a thin rim of perineurium, elongated cells with a wavy nucleus or a buckling of the nucleus, comma-shaped nucleus, interspersed with the collagen bundles, wire-like collagen, and at places giving a shredded carrot appearance, mucin-rich stroma, increased number of mast cells with thin blood vessels, distorted organoid structures resembling Wagner-Meissner corpuscles, as well as patchy areas of hypercellularity with atypia. There was no mitosis and no necrosis in this case. So all these things put together, we come to a straightforward diagnosis of neurofibroma with atypical features. So these were the few DDs which were given by my postgraduates. So coming to the discussion part. So this majority of the tumors of the peripheral nervous systems are derived by the Schwann cells and their peripheral nerve elements. So this is a WHO classification of the nerve sheath tumors, both benign as well as malignant nerve sheath tumors. So coming to the neurofibroma or neurofibromatosis proper, so it can be either localized, diffuse or plexiform neurofibroma. So these neurofibromas show the combined proliferation of all the elements of the peripheral nerve, that is axons, Schwann cells, fibroblasts, and the perineurial cells. So if you want to highlight the axon part, we can go for the silver staining or the neuron-specific rays or the neurofilaments, whereas Schwann cells by S100, fibroblasts by M19, and perineurial cells by EMA. So if you have a multiple lesions, we have to think about neurofibromatosis or von Reckling-Hussen's disease. So as you all know, this is an autosomal dominant inheritance which has two subtypes, NF1 and NF2. So what is important here is in case of neurofibromas which are associated with this syndrome, there is 15% chance for malignant transformation. That becomes very important here. So in our case, as I said, it was an young child. On continuous digging for the history, we could get a history of similar tumor which was excised in the 2 years back. And the present case, we have a neurofibroma with atypical features. So at this context, what do you all think, or what has to be ruled out? Anyone? So neurofibromatosis has to be ruled out. So these are the diagnostic criteria for the neurofibromatosis. Any two or more of the following should be present. So 6 or more cephaloid spots of more than 0.5 centimeters in pre-pubertal age group and more than 1.5 centimeters in post-pubertal age group. So 2 or more any type of neurofibromas, or one plexiform neurofibroma will do. Then you have an axillary and inguinal frecklings, optic glioma, leash nodules, sphenoid dysplasia, and any first degree relative with the neurofibromatosis 1. So these are the criteria which are followed for the diagnosis of neurofibromatosis. So coming to the clinical features as such, when it presents in an young adult, it is relatively very small and soft in consistency, presenting as a dermal or a subcutaneous nodule. So oral lesions can also be seen in few percentage of cases. Multiple conventional neurofibroma, which we should think of neurofibromatosis and rule out by seeing all the criteria which I have told. So diffuse neurofibromas are usually deeply situated and the patient can present you with pain and paresthesia. So gross description, so usually this is not encapsulated, much softer and more gelatinous in consistency when compared to that of a schwannoma. See, superficial tumors like this present you as a small pedunculated nodule protruding out from the skin. The deeper tumors are much larger in size. Sometimes it can give rise to tortuous enlargement of nerve bundles, giving a tuber root-like pattern like this. This is a picture of this thing. Then plexiform neurofibromas will show or involve mainly the major nerve trunks, showing varying degrees of nodularity. So it is described as a bag of worm appearance. So pathological features we have already discussed the same thing. There are many subtypes of neurofibromas, plexiform neurofibroma. So to make a diagnosis of plexiform neurofibroma, you have to see the plexiform architecture both grossly as well as microscopically, not just microscopy. So diffuse cutaneous neurofibromas, you see the entrapment of the adnexal structures and also infiltrates into the surrounding fat tissue. Then you have epithelioid granular cell neurofibroma and pigmented neurofibroma where you can get a melanin pigment. So this neurofibroma is weak, shows weak positivity for S100, focal carnitine, and strongly positive for CD34. So what is absent in this neurofibroma? You have to make sure that there are no verrucate bodies, there is no palisading of the nucleus, and there is no thickened or hyalinized blood vessels. So these are absent in neurofibromas. So when you have seen a case of neurofibroma, now you can see this picture. So you can see the two areas. One is a hypercellular area here, and here there is a hypocellular area. So hypercellular areas are known as Antony A areas, and hypocellular or paucicellular areas are known as Antony B areas. The classical feature that you see here is a verrucate bodies with a palisading of the nucleus. This is a classical verrucate body. You also get a thickened hyalinized blood vessels. You can see the hemocydin deposition. You can see the histiocyte-like cells in this. So this is a classical schwannoma. Because you have seen the neurofibroma, I'm showing schwannoma also here. So what in this picture, what you're seeing is a plexiform architecture microscopically and showing a more cellular areas containing predominantly of verrucate bodies. There is no biphasic pattern here, mainly cellular areas with a verrucate bodies, no necrosis and no myxoid change. So this was a plexiform schwannoma. So one of the DD offered was a fibrosarcoma. So generally in fibrosarcoma, we see fibroblastic proliferation, which shows a herringbone pattern with increased mitotic activity. That type of pattern was not seen here. And somebody told lipoblast also. So lipoblast were also not seen in this case. So MPNST, if you are thinking, so in MPNST, we have to see the diffuse increased cellularity with a remarkable cytological atypia with increased mitotic activity and necrosis, which was not seen. So cellular areas in case of MPNST can be of a fibrosarcoma-like pattern, growth pattern, or it can show epithelioid morphology, or it can also show heterogeneous differentiation in the form of chondrosarcomatous, osteosarcomatous, or rhabdomyosarcomatous area. So if you are seeing a rhabdomyosarcomatous area, we call it as a malignant triton. So this is a proposed nomenclature of NF1 associated nerve sheath tumors. So as in our case, atypical neurofibroma of undetermined biological behavior, we see all the features, whatever we have discussed, with increased hypercellularity as well as the mitosis of more than 1 per 50 hypophil, there is no necrosis. Whereas if you want to diagnose low-grade MPNST, then you see all the features of atypical neurofibroma along with mitosis of 3 to 9 per 10 hypophil and no necrosis. And if you want to diagnose high-grade MPNST, we see all the features of low-grade MPNST along with increased mitotic activity of 10 per 10 hypophil and necrosis. So take-home message in this case is plexiform neurofibroma. When you're diagnosing, the plexiform architecture should be present both grossly as well as microscopically. So if you see the plexiform architecture microscopically only, so don't jump into the diagnosis of plexiform neurofibroma just for making a diagnosis of neurofibromatosis 1. Thank you.
For our PGs, questions like myxoid tumors of the soft tissue. This could be a exam question. And what are the other tumors that show myxoid change? So PGs who are watching this, please make a list and then you can answer at the end. Myxoid tumors, which are the soft tissue, or tumor showing myxoid change? So we'll wait for the answer at the end.
Case number 2, 40 years female with the solitary thyroid nodule. FNAC was done. Yeah.
Okay, next.
That was the FNAC, madam.
Okay.
And yeah.
Yes.
Yes, ma'am. Yeah, they can present. I think they can present.
Okay.
Good morning. I'm Dr. Krupa from JJ I've been allotted case 2. Ginseng stained moderating cellular hemorrhagic smear shows micro, macro, and normal follicles with few cells in singles. These cells have abundant cytoplasm, hyperchromatic ground nucleus, and few showing nucleomegaly and inconspicuous nucleoli against a background of cyst macrophages. No nuclear features in the form of grooving, inclusions, and overlapping seen. No amyloid material or colloid seen. My probable diagnosis is suspicious for follicular neoplasm, Bethesda category 4.
4. In view of microfollicles and no colloid. Histopath images shows an encapsulated neoplastic lesion composed of varying sized follicles and few arranged in papillary pattern. These follicles and papillae are lined by cells having high MC ratio with optically clear ground glass nucleus, irregular nuclear counter, few showing prominent longitudinal grooves and pseudo-inclusions. Also seen nuclear crowding and overlapping with scant eosinophilic cytoplasm. Lumen of the follicles is filled with homogeneous eosinophilic colloid and scalloping. Stroma is minimal, no suboma bodies and capsular invasion seen. My probable diagnosis is follicular variant of papillary thyroid carcinoma.
So 40 years female with a solitary thyroid nodule and FNAC was done. Actually, really sorry, the smear is not that good, but you can just make out the moderate cellularity in this case. So here you can make out some follicular cells arranged in clusters as well as microfollicle formation. Some amount of overcrowding can be seen here. So in this case, it's much more clear. You can see some atypical follicular cell arrangement showing cell crowding and the microfollicle formation. So what is actually a microfollicle? It's nothing but a flat group or sheets of cell having less than 15 follicular cells arranged in a form of a circle, which is at least two-thirds complete. So in the so there are many microfollicles here. So microfollicular architecture as well as some amount of overcrowding. There was some nuclear enlargement here and there, and background has a single cells. So this was given as a suggestive of follicular neoplasm on FNAC, and the same thing we had received the specimen which showed a thyroid nodule which was entirely surrounded by a thin capsule. So what you're seeing in this picture is there's a clear demarcation between the tumor and the normal thyroid tissue, and there is no capsular or vascular invasion here. So pattern, follicular pattern of growth, we could see all the three types: macrofollicular, microfollicular, and normofollicular growth pattern. So varying follicular pattern we could see. There are some amount of papillary infolding and abortive papillary structures. There is no sumum bodies in this case. So thick colloid with a papillary infolding into the space. So in these two pictures clearly show you the follicular arrangement along with the nucleus, which are showing overcrowding and overlapping and clearing of the nucleus. See, overcrowding, overlapping, nuclear clearing, nuclear membrane irregularities like nuclear folds, crescent shaped nucleus, and also nuclear grooving here and there. See the ovoid shaped cells with the nuclear grooving, which is clearly seen, and clearing at this side. see the clear grooving, which is much more clear in this picture. So clearing as well as grooving. Occasionally, we could also see intranuclear cytoplasmic inclusions. So all these things put together, we came to the diagnosis of non-invasive follicular thyroid neoplasm with papillary-like nuclear features. So what is this non-invasive follicular thyroid neoplasm with papillary-like nuclear features? So as the name itself tells you, it is a non-invasive tumor having an extremely low malignant potential. So what are the criteria which are present or criteria should be present to call it as non-invasive tumor? Is a clear encapsulation or clear demarcation. Follicular growth pattern can be either normofollicular, microfollicular and macrofollicular pattern. Papillae, if they are present, should be less than 1%. There are no small bodies. Less than 30% solid trabecular or insular growth pattern. The nuclear features of papillary carcinoma thyroid should be present. The nuclear features we can see based on the size and the shape. We see the nuclear enlargement, overcrowding, overlapping, and nuclear elongation. Membrane irregularities like irregular nuclear counter, crescent-shaped nucleus, grooves, folds, and pseudo-inclusions can be seen. Chromatin, chromatin clearing, margination, grooving, as well as glassy appearance. So these things should be present to call it as positive for nuclear features. And these features can be seen either focally or patchy, or they can be diffuse in nature. No lymphovascular invasion or no capsular invasion should be present. There is no tumor necrosis and no high mitotic activity. So these criteria should be present to call it as non-invasive follicular thyroid neoplasm with papillary-like nuclear features. So what exclusion criteria, what you see is, if there is more than 30% solid area or trabecular or insular growth pattern, and if tumor shows more than 3 mitosis per 10 hyperfield and there is a tumor necrosis, you have to think of fully differentiated thyroid carcinoma. So what are the differential diagnoses? So earlier it was called as encapsulated follicular variant of papillary carcinoma thyroid. Now it is called as non-invasive follicular thyroid neoplasm with nuclear papillary-like nuclear features. So first is follicular adenoma. So generally in follicular adenomas, we don't see papillary carcinoma nuclear features. If it is a conventional papillary carcinoma thyroid, we see classical papillae with a fibrovascular core. If it is invasion, in case of encapsulated variant, we see the capsular or the vascular invasion. So about what is important here is about half of these cases are cytologically diagnosed as follicular neoplasms. So elderly female, asymptomatic, presented with the enlarged neck mass, which was mainly of cosmetic reason, mainly for the cosmetic reasons. Solitary thyroid swelling, it was a cold nodule on scanning. Yeah. So these are the pictures. Shall I stop sharing?
Yes, Lord.
Yes.
A very good morning to one and all. I'm Dr. Melanie and I have been allotted case number 3. HME stain sections show a neoplastic lesion composed of tumor cells arranged in trabeculae, papillae, and few giving a tram-track appearance. The tumor cells are arranged as a single layer of tall columnar cells with the cell height 2 to 3 times its width, having abundant finely granular eosinophilic cytoplasm with well-delineated cell borders, enlarged nuclei with numerous grooves and few showing pseudo-inclusions, nuclear overlapping and chromatin clearing. Focal areas of calcification are also noted. Since in all the images, majority of the cells appear to be 2 to 3 times longer or taller than their width, I am assuming more than 30% of the tumor is composed of tall cells, and I would like to give a first differential of papillary thyroid carcinoma, tall cell variant, with my second differential being classical papillary thyroid carcinoma with tall cell features. Thank you.
Yeah. So this is the first slide. So there is in this picture you can see the parallel courts of tumor cells which are  giving a railroad or a tram track pattern. So this is the follicular arrangement of the cell, and observe this cell. They are 2 to 3 times as tall as they are wide, having an abundant clear to eosinophilic cytoplasm. In this case, shows a clear papillary structure with a fibrovascular core. Again, branching papillary structure lined by the similar type of cells. Tall cells with abundant eosinophilic to clear cytoplasm. So if you observe, you can see intranuclear cytoplasmic inclusion, which is much more clear. See here, 1, 2, and 3. These are the intranuclear cytoplasmic inclusions. If you see the colloid, it is very thick and chewing gum like colloid. Clear inclusion and some amount of nuclear grooving here and there. So what all we saw, the cells which are 2 to 3 times as tall as they are wide, with abundant eosinophilic or oncocyte-like cytoplasm with the typical nuclear features of papillary carcinoma thyroid. The growth pattern, what we saw in our case was papillary, trabecular as well as follicular growth pattern were nuclear pseudo-inclusions, and this constituted more than 30% population. The tall cells were in the more than 30% population were of tall cells. There were no evidence of somoma bodies. There is no stratification. There is no squamous modules in this case. So clear-cut, straight diagnosis of tall cell papillary carcinoma thyroid was given in this case. Good presentation, thank you, by the PG. So coming to the discussion part, this tall cell papillary carcinoma thyroid is generally seen in old age, very aggressive tumor, showing an extrathyroidal extension as well as a metastatic disease in most of the cases associated with BRAF mutations. So DD, what you have to think or what can be thought was a columnar cell carcinoma, and this columnar cell carcinoma will generally show the columnar cells which are showing pseudostratification and which lack the classical nuclear features of papillary carcinoma thyroid. They can show the pattern, papillary pattern or glandular spaces lined by stratified columnar cells. Many places they can show cytoplasmic, subnuclear cytoplasmic maculations. So if you are thinking in case of columnar cell carcinoma, then metastatic tumors has to be ruled out, especially from the colon and the endometrial tumor. So based on the IHC, these metastatic tumors are usually negative for thyroid transcription factor 1, whereas columnar cell carcinomas will be positive for TTF1. So I'll just share the picture of a columnar cell carcinoma. So this is a classical picture of a columnar cell carcinoma showing a glandular as well as papillary architecture with the stratification of the cells. At places very small cytoplasmic maculations can also be seen. So if it is a classical papillary carcinoma thyroid and if you get more than 10% tall cells, that has to be mentioned in the report, because generally if presence of tall cells carry a worse prognosis when compared to the normal counterpart. So if you see papillary carcinoma thyroid with more than 10% and less than 30% tall cells, we diagnose it as a papillary carcinoma thyroid with tall cell features. If it is more than 30% tall cells, it is a straightforward diagnosis of tall cell papillary carcinoma thyroid. Thank you. ACE4, I'll just show the pictures. So it was a 30-year female with a bilateral ovarian cyst. Laparoscopic cystectomy was done. We received 2 containers, both containing a cyst as well as a solid area. I'm really sorry for the picture because they had cut open and sent the cyst, and because it was cut open, it is already folded like this. But you can see that bilateral solid areas with a yellowish appearance cut section. So these are the pictures. Yes, I think the PG can present.
Hello everyone, I'm Dr. Priyanshi and I'll be presenting case 4. All images given show cyst wall lined by a single layer of ciliated tall columnar epithelium.
Also seen are neoplastic cells arranged in nests composed of transitional cells within a fibromatous stroma. These cells have round to oval nuclei with prominent nucleoli and few showing nuclear groups with scant eosinophilic cytoplasm. Keeping all these points in mind, I would like to make a diagnosis of mucinous cyst adenoma with Brenner's tumor. Thank you.
So this is a bilateral cystic tumor with the solid areas showing a homogeneous yellowish appearance grossly. So microscopically, we could see the two components here. This is the first component and this is the second component. The first component here is a cyst lined by tall columnar cells, mucin secreting cells. The second component is a nest of transitional epithelium showing clear cell change here. See, this is a cyst wall lined by tall columnar mucin secreting cells. And the second component here, you can see the nests of transitional epithelial cells having a coffee bean shaped or elliptical nucleus with a grooving surrounded by a dense fibromatous stroma. So the same transitional epithelial nest with a central cystic change to clear cell change. So this you can make out the nucleus clearly, coffee bean or elliptical shaped nucleus with the nuclear grooving. This is a cystic change. So in this picture, you can see the architectural complexity of the gland with the budding as well as papillary outpouching. See the outpouching here with a dense fibrous stroma surrounded by nests surrounded by a dense fibrous stroma. So these are the ribbons of transitional epithelium arranged back to back with some amount of cytological atypia. So all these things put together, we diagnose actually a rare, common slide, but a rare presentation, bilateral mucinous cyst adenoma ovary with a proliferating Brenner tumor. So common slide, but rare presentation. So coming to the Brenner tumor, which are most commonly seen in 5th and 6th decade of life, but can occur at any age group. So we divide them into benign, proliferating as well as malignant Brenner. So benign Brenner will show you the smooth contoured nest consisting of a transitional epithelium having a coffee bean shaped or a elliptical shaped nucleus with a grooving. You can see the mucinous metaplasia in these cases, microcyst formation, calcification, and in 10% of the cases, it can be associated with mucinous cyst adenoma. Whereas the proliferating Brenner will show you the architectural complexity of the nest, showing the budding as well as the papillary outpouching, but there is no stromal invasion. Whereas in malignant Brenner, we see the stromal invasion. So if you see a Brenner tumor with extensive mucinous metaplasia, we call it as a metaplastic Brenner. So what I want to tell you in this case is the patient had an endometrial hyperplasia. So what you can think at this stage, if she had an endometrial hyperplasia with a Brenner tumor?
Estrogen, it's secreting.
So is it a common tumor, hormone producing tumor?
It is a functional tumor.
Okay. Okay. So generally, very rarely these Brenner tumors can be associated with estrogen production, giving an altered estrogen and progesterone ratio. Okay, and even very rarely it can be associated with pseudo-Make syndrome, which has an ascites as well as hydrothorax along with the Brenner tumor. The stromal component of the tumor is thought to produce the estrogen or secrete the estrogen. So at this point, I would like to tell you the hormone producing tumors of the ovary. So what are the hormone producing tumors of the ovary, you know? Okay.
Granulosa cell tumor.
Yes, yes, very good, very good. So there are, you can classify them into estrogen producing tumors and androgen producing tumors. So in the estrogen producing tumor, the most common is a granulosa cell tumor, so which can present at any age. So if it is presenting at a prepubertal age group, the patient can present you with early menarche. So if they are presenting at a reproductive age group, the patient can present you with endometrial hyperplasia, and postmenopausal age group, either hyperplasia or adenocarcinoma. So other estrogen producing tumors are tecoma, and very rarely Brenner tumor also can produce estrogen. So So androgen producing tumors, mainly Sertoli Leydig cell tumor, Hylas cell tumor, and Leukoid cell tumor. You can also diagnose these tumors based on the age group and presentation. For example, if the patient is pre-pubertal age group and has a virilizing features, you should think of Sertoli Leydig cell tumor. If she has a pre-pubertal age group with feminizing features, think of juvenile granulosa cell tumor. If the patient is reproductive age group presenting with a dysfunctional uterine bleeding, think of granulosa cell tumor. If she is presenting with virilization, think of Sertoli Leydig cell tumor, Hylas cell tumor, and very rarely granulosa cell tumor can also be androgen secreting. If the patient is postmenopausal age group and presenting with bleeding, then you think of granulosa cell tumor. If it is virilizing, you think of Hylas cell tumor. Thank you. Case 5, I'll just show the pictures. So 40-year female, right breast lump. FNAC, they had given it as atypical hyperplasia, and the biopsy was done from outside somewhere else, and it was just reported as no evidence of atypical hyperplasia. The excision was done, and this was the breast lump, what we saw. And these are the pictures. Yeah.
I'm Dr. Maunika and have been allotted case number 5. Image studied shows infiltrating neoplastic lesion where the tumor cells are monomorphic, discohesive in appearance and are arranged in Indian file pattern and few in cords, along with areas of desmoplastic stroma in between the tumor cells. These tumor cells show mild atypia, round to oval nucleus and vesicular chromatin with scant cytoplasm. Few of the cells have prominent 1 to 2 nucleoli. Also, a component of LCIS and probably a targeted appearance is seen in the images studied. Based on these findings, I would like to give a diagnosis of lobular carcinoma with LCIS component. Thank you.
Yes, ma'am, we can see, ma'am.
Yeah. So case 5, 40-year female with a right breast lump. So FNAC, they had told atypical hyperplasia, and core biopsy, they had just told that there is no evidence of atypical hyperplasia, and the excision was done. This is a tumor which we have received. So irregular gray white tumor with the which is infiltrating into the surrounding adipose tissue. Poorly delimited tumor. Microscopy. What you're seeing here is a terminal duct lobular unit, which is showing completely filled by the cells. This is a lobular carcinoma in situ, filling and expanding the terminal acini in the terminal duct lobular unit. So these slides shows the proliferation of the tumor cells which are running in a single file pattern or an Indian file pattern, which are loosely cohesive. Very rarely non-classical pattern can be seen, like solid pattern, which can show the solidness of tumor cells, whereas alveolar pattern where you can see the aggregates of tumor cells of more than 20 cells together. So these are the non-classical patterns which can be seen sometimes. So this is classical pattern of linear or Indian file pattern, and also single cells here and there. So these single cells are arranged around the duct, giving an targetoid appearance. And very rarely, if you look and search for it, you can get a intracytoplasmic lumina, the cells having a scant cytoplasm with the intracytoplasmic lumina can be seen. So these are the intracytoplasmic lumina which we saw here and this one. If you look and search for it, you can definitely find them. So based on all these things put together, we came to the diagnosis of invasive lobular carcinoma. So what are the things should be present to call it as invasive lobular carcinoma? The cell should be in the single file or Indian file or even single cells. Sometimes you can see the targetoid pattern. Discohesive cells, small monomorphic cells lacking atypia, which shows round or ovoid nucleus having a scant cytoplasm, and you can get an intercytoplasmic lumina. Sometimes you have to look and search for it. Mitosis is not frequent. Desmoplastic reaction and the necrosis is uncommon in these cases. It can show the non-classical patterns like solid pattern, alveolar pattern, and also tubulo-lobular carcinoma. Can also get pleomorphic lobular carcinoma, histiocytoid type, apocrine type, and signet ring cell type. So these tumors are generally positive for estrogen receptor, progesterone receptor, and androgen receptor, and negative for E-cadherin and HER2. So 85% of the cases are classified as a luminal A subtype by gene expression profiling and immunohistochemistry. So this luminal A subtype means they are ER/PR positive, whereas HER2 negative. Luminal B subtype means all three are positive, whereas basal-like all three are negative, and HER2 positivity will show only HER2 positivity and hormone receptor negativity. So majority of this invasive lobular carcinomas are luminal A subtype. And 50 to 80% of these invasive lobular carcinomas are associated with the lobular carcinoma in situ. So how to differentiate this invasive lobular carcinoma with infiltrating ductal carcinoma? So generally these invasive lobular carcinoma will show no duct formation. Classical arrangement what we have described will be seen, and they are generally E-cadherin negative. So if you are thinking of tubulo-lobular carcinoma, so what is this tubulo-lobular carcinoma? So this is a type of tumor where you can see the invasive lobular carcinoma component along with some components where you can see the small round angulated tubules without lumina, and these areas where you can see the tubular cells or angulated tubules, they show positivity for E-cadherin, whereas in classical invasive lobular carcinoma are E-cadherin negative. One more confusion where you can get is lobular carcinoma in situ in sclerosing adenosis, which may look like invasive lobular carcinoma. So this sclerosing adenosis, you can see the myoepithelial cells clearly, whereas infiltrating lobular carcinoma, there is absence of myoepithelial cells in the invasive part. So one more thing what you have to know here is a mixed ductal as well as lobular carcinoma. You will call it as mixed ductal and lobular carcinoma only if you see 50% of the component consisting of a lobular tumor, invasive lobular component. And these invasive lobular component areas are E-cadherin negative, whereas ductal component areas will show E-cadherin positivity. One more thing we have to differentiate it from is the infiltrating ductal carcinoma having a lobular features. So infiltrating ductal carcinoma with lobular features shows E-cadherin positivity, which supports a ductal origin. So take home message in this case is, so invasive lobular carcinoma is more frequently hormone receptor positivity and demonstrates a higher incidence of synchronous contralateral primary tumors, presents more frequently with multicentric disease and metastasizes to distinct sites such as meninges, serosa, and retroperitoneum. Thank you. Case 6, I'll just show the pictures. So elderly male admitted to the hospital, was in intensive care unit for a few days and then expired. So these are the pictures, microscopic pictures. Yes. Yeah, the PG can present.
Yes, ma'am.
Hello everyone, I'm Dr. Pradeep Kumar Reddy. I'm presenting case 6. The images provided are HNE stain sections of lung, kidney, heart, and blood vessels. Sections studied from lung show an area of infarction. The alveoli are distended with loose cotton wool-like exudates and sparse inflammatory cells. These are also accompanied by blood vessels with thrombi and some anthracotic pigment in the lung tissue. Section studied from the kidney shows similar exudates in some glomerular areas. There are no areas of infarction, but some congested blood vessels with small thrombi. Section studied from heart shows cardiac tissue with surrounding adipose tissue and small blood vessels with thrombi. Section studied from other large blood vessels show atherosclerotic changes in the vessel wall. With these findings, my impression is pulmonary thromboembolism with DIC with ICU acquired infection, probably pneumocystis carrying.
Yeah. Case number 6. Elderly male admitted to the hospital, was in intensive care unit for a few days and then expired. So in this picture, actually what you are seeing is a lung tissue. So alveoli showing intra-alveolar hemorrhage as well as edema, intra-alveolar edema. So this rounded part, I'll come to it later. So this picture, you can see the edema here and some desquamated cells inside the alveoli. And this is some pink colored material you're seeing here. What is it? This is a hyaline membrane formation, early change that you can see. Along with the pulmonary edema, there is some hyaline membrane here and desquamated cells. So one more area showing hyaline membrane along with the intra-alveolar hemorrhage and edema. See the edema and hemorrhage and the hyaline membrane formation very clearly you can see. And there are some multinucleated cells in the lung parenchyma. These are megakaryocytes which are increased in the lung parenchyma. So this picture you already described, edema, hemorrhage as well as some desquamation. But what you are seeing here in the blood vessels, what you are seeing here, what are these unstained areas? Vacuoles. What are the things you have to think if you get an unstained area? Fat, then
Glycogen.
either it has to be air or fat or glycogen. Okay, so this is a fat globules along with a marrow element here in the blood vessel. One more area, this is a blood vessel showing a multiple varying sized fat globules along with the marrow particles. So this is a linear fat vacuoles in the vessels in between the alveoli. The same thing highlighted, these are the fat globules or the vacuoles in the capillaries. This is a special stain for fat. So these are the fat globules highlighted here. So this is a kidney. Again, you can see the large vessel showing some unstained vacuoles here and there. So these are the fat globules. And these are the glomeruli. And you can see some unstained areas here. So see here in the glomeruli, these are the fat emboli within the small capillaries of the glomeruli. See here, these are the fat globules inside the glomeruli. This one here, here. So this even I had just put a picture because this was seen in the same case. This is a cardiac tissue, this is a vessel, and there are some small vacuolated areas here. Not very sure, I had not reported about this in the diagnosis, but I just put the picture because it was in the same case. Same case, the coronary vessel show atheromatous area, but inside the vessel you can see some adipose tissue and some small area which showed some cells. This could be actually a marrow element along with the adipose tissue, but I have not reported this thing because I was not very much sure because the morphology was not that clear in this case. So what all? I didn't tell you the history because if I had told it would have been very easy. The patient, it was a case of road traffic accident, admitted to the hospital, was in ICU and then expired. So what all we saw, the features we saw alveoli, and also denuded type 1 pneumocytes. Okay, necrosis of the endothelial cells with microthrombi formation and hemorrhage. Whereas in proliferating phase, you can see the proliferation of myofibroblasts and proliferation of type 2 pneumocytes. In the fibrotic phase, we see collagenous fibrosis. So what you're seeing here is just I wanted to tell you about the type 1 and type 2 pneumocytes. So type 1 pneumocytes are generally flat, whereas type 2 pneumocytes are slightly cuboidal in shape. So type 1 are mainly involved in the gaseous exchange, whereas type 2, they produce surfactant. So in exudative phase, what happens? There will be denuded type 1 pneumocytes, whereas in proliferative phase, we see proliferation of type 2 pneumocytes. So I want to just tell about the fat embolism syndrome. So this fat embolism syndrome is nothing but when the fat enters the bloodstream, it can give rise to various symptoms. So generally the symptoms begins within 24 hours to 72 hours. So classical presentation is mainly petechial rash along with the decreased level of consciousness and shortness of breath. The patient can even have fever with decreased urine output, lipiduria, and the risk of death is 10%. So there can be multiple causes of fat embolism. There can be traumatic cause as well as non-traumatic cause. But the most important cause of fat embolism is a fracture of the bones, particularly the long bones and the pelvis. So there are two theories which are proposed for fat embolism. One is the mechanical theory and the biochemical theory. In the mechanical theory, we see that there is an raised intramedullary pressure which forces the fat as well as the marrow element to move into the circulation and reaches the pulmonary circulation. Whereas in biochemical theory, what happens? These whatever the fat which has reached will be broken down into free fatty acids, and these free fatty acids will be toxic to the alveolar epithelium as well as the endothelium. There can be raised levels of interleukin 6 also in this case because of a free fatty acid injury. So these fat globules may pass from the lung circulation into the systemic circulation, and they can get lodged into various systemic organs like most commonly brain, kidney, skin, eyes, and myocardium. So clinical features are very important for the diagnosis. These are the major and minor criteria. So this is called as a GERD criteria for diagnosing fat embolism syndrome. The major being a petechia, hypoxia, and cerebral symptoms. The scoring system can also be given for the fat embolism. This is a Masson scoring system on microscopy, grade 0 to grade 4. Grade 0 is no emboli. Grade 1 is emboli, which is not immediately apparent in 2 or 3 microscopic fields, and 4 when there is emboli present in potentially fatal concentration. So take home message in this case is a fat embolism syndrome is a physiological response to the fat which is occurring in the circulation. So most commonly you see fat embolism whenever there is a closed fracture and bilateral tibial fractures. So it very rarely, it can also occur in sickle cell crisis, which induces the hypoxia and bone marrow necrosis. So it can release the marrow elements into the circulation. And triad of fat embolism syndrome is hypoxia, altered neurological deficits, and petechial rashes. So this was a case of fat embolism syndrome. Thank you. So these are the slides actually we see routinely. And if you have an autopsy reporting or medical legal cases, you generally encounter these type of cases.
Thank you, Veena, for the wonderful presentation. I'd like to ask Ramya to give the vote of thanks. Any questions? Postgraduates and yeah, postgraduates and faculty who want and ask any questions, please do come forward and ask the questions.
Good morning, ma'am. Ma'am, I have a doubt on that third case, NIFTP, non-invasive follicular neoplasm with papillary-like nuclear features. Are you hearing? Are you hearing, ma'am?
Yeah, please tell me.
Ma'am, that papillary criteria was like less than 1% of papillary, less than 1% was the criteria, ma'am.
Yes, yes.
Yeah, ma'am, I just wanted to add a note, ma'am. Actually, I just passed recently I passed that criteria has been still more tightened to be as known papillae in the lesion, actually, ma'am. To 2020. Yes, ma'am.
Yeah. Yeah, that's what we could see, actually abortive papillary structures and papillary infoldings. But true papillae with the fibrovascular core was not seen.
Yeah, so there was no papillae. Ma'am, in case if we get a single papillae with small, very minute fibrovascular core, where should we keep it, ma'am, actually, in the diagnosis? Whether it comes in a NIFTP or will it come in a follicular variant of...
So according to the book, he gives as less than 1% true papillae. So if it is less than 1%, we can call it as non-invasive follicular thyroid neoplasm with papillary-like nuclear features only.
Okay, ma'am. That was my doubt. Thank you, ma'am.
Yeah, thank you.
So, any other questions?
Something is displaying chat box.
So it's my privilege to propose a vote of thanks on behalf of Department of Pathology. I thank our beloved patrons, Dr. Shamnur Shivshankarappaji, and our chairman, SS Mallikarjun sir, for always supporting us. And I extend my gratitude for our principal, Dr. B.S. Prasad sir, and medical director, Dr. Arun Kumar sir, who never told no for any academic events which we conduct in our department. And I thank our ever enthusiastic and ever smiling, our HOD ma'am, who is always a backbone for this slide seminar. And I thank our today's guest speaker, Dr. Veena ma'am, for sparing her valuable time to share her knowledge with us. As ma'am told, it was a feast for all of us, ma'am. Thank you so much, ma'am. And I thank all my colleagues for constant support. I thank all the postgraduates for their active participation and all the delegates for participating in this slide seminar. Thank you one and all who are present here.
So one question
Yeah.
is missing.
Yeah, one question by our senior neurologist, Dr. Krishnamurthy sir, who's been watching with his postgraduates. He wants you to elaborate on Antony A and B pattern and neurofibroma.
A and Antony B areas are classically seen in schwannomas. So Antony A areas are hypercellular areas, whereas Antony B areas are paucicellular. We generally see verruca bodies in cellular areas, showing a centrally paucicellular area surrounded by a palisading of the nucleus.
Thank you, Veena, for the elaborate slide seminar. Yeah.
Ma'am, I once again want to thank Dr. Shashikala madam. Thank you, Kavita ma'am and Deepthi madam for the constant support. Thank you, ma'am. Thank you, all of you.
Thank you so much.
Yeah, thank you, ma'am.